Oh, you can show us that? Okay, that's
Were you going to do that?
Yeah, go for it.
So
You're up there.
when we do an inversion ankle sprain, what is the ligament that tends to get injured most commonly with an inversion ankle sprain?
Oh, maybe you're doing a different one.
Yeah, I did.
Talocrib. Interior table fib.
Oh,
Posterior
that took way too
table.
long. Yeah, I got it. I just almost dozed off. Anterior talofib. So what happens is we come in like this, and between the fibula and the talus, that ligament right there gets injured. So what happens is, as we injure these lateral ligaments, the calcaneofibular or the posterior talofib with an inversion sprain, we've injured a ligament, so sometimes one of the bones that gets held down becomes, I don't want to say unstable, but it doesn't sit where it's supposed to. And what we get is we end up with this is way advanced and we didn't really talk about this, but that fibular head sits in a position where it's not comfortable, and it ends up kind of gliding a little bit anteriorly, and we get an impingement in through here. So at end range dorsiflexion, they jam right in through here and they get discomfort. So when I'm coming down the stairs like this, they'll go like this and they'll say, boy, it just pinches right in the front. Or they'll try to squat and they'll go, I can't go into end range dorsiflexion because it pinches right in through here. So your fibular head is basically displacing a little bit anteriorly. Okay? So just go with me on this again. That concept's a little beyond what we talked about.
No, we have this in the PowerPoint.
Oh, giddy up. Hold that right there. So what I want to do, this is called a mulligan. A guy by the name of Mulligan, another therapist who has a lot of good techniques. I'm going to grab this fibular head, and with my white tape, remember, I'm not applying any tension. I'm just putting my base down. And I'm going to wrap around to here. Okay, so there's my white. I've got minimal tension, but I'm starting here and I'm coming around that way. So if I've got a fibular head that's displacing anteriorly with this injury, I want to do basically a joint mobilization, and I'm going to hold it in place with this tape job. So I put my tape job, start with my tape where I want it to be. Relax here, and I'm going to push the distal fibula posteriorly. I'm going to do a posterior glide of this fibula, gliding it posteriorly, and then I'm going to take this tape and I'm going to pull and hold it in that position. And then I'm going to release my glide. So I do my mobilization, and then I use the tape to lock it down. So if this is effective, it's going to kind of hold. Now again, we're not grabbing the actual bone, we're holding the skin that's over the bone, but it effectively will improve the orientation of that fibula and prevent it from translating anteriorly, and it'll have less impingement in through here. So when are you going to use this? If you have an ankle sprain, and as you're regaining your range of motion, the end range dorsiflexion, they have a lot of pain in this spot. The thing about this taping is you can't hurt anybody with it. So if you have somebody that's got pain here after an ankle sprain, try this tape job and it'll work. If you tape it and it doesn't work, you've lost 3 minutes of your life. It's no big deal. You just give it a shot, and I never promise people the world. I'll say, let's see if that takes maybe 30% of that pain down. So if they were a 5 out of 10 and they're down to 2 out of 10, first they think you're a genius. Secondly, they can do more exercise, and they're more optimistic about the whole thing. So it's not going to fix everything, but it can definitely help. So this is a mulligan technique to do a posterior glide of that distal fibular head. It works after